is a really important group to evaluate. So PMMR subgroup. Flora, what are your thoughts here? I have kind of this is a Matt slide, GY08, Ruby, and a 10 to the left, and then Duo a little bit off to the side, since the Duo trial was the only trial here to evaluate not just an immunotherapy strategy, but now adding a PARP inhibitor. So Flora.
But PMMR is a Jurassic Park.
Hey, Mansoor, I said
no,
floor.
I think,
Floor.
no, I think this is a really interesting slide. And I think the molecular data in Ruby is very informative in this, or helps us maybe to understand, is this really a difference between the two different drugs in PMMR? Or is this driven by the molecular subgroups? And we saw 54% of the NSMP in Ruby in the PMMR group. So is that what is driving the efficacy or the hazard ratios in these groups? And it will be interesting to see what GY018 has. And is that because they maybe have a higher sera subgroup in this population? And is that what's driving that hazard ratio down a little bit more? And yeah, you're right. We're never going to compare the dostarlimab versus pembrolizumab versus any of the other drugs, most likely in this population. But looking at the molecular profiles is going to be critically important.
So both Mansoor and Matt said that they wouldn't add olaparib to an immunotherapy strategy yet in endometrial cancer. And I just want you to explain that a little bit further.
You want Flora to do that, or you want me to do that?
Mansoor or Matt?
Oh,
Matt, go ahead.
Do you want to go to that slide? I actually, you mentioned there was an adjuvant trial that was done in somewhat of an unselected patient population. Do you want to cue that slide?
I will. Can you do me a favor though? Can you just talk a little bit about this one?
Yeah, we can talk on this one. Sorry. Yeah. So, definitely the addition of the PARP inhibitor is something we're all very familiar with in GYN cancers from our ovarian cancer experience. And differences in PFS, I think, are intriguing, but I'm really want to be cautious, just like we have in ovarian cancer. This OS signal, to me, in the adjuvant trial was actually the wrong direction. And I know it's early. I know it was a randomized phase 2 study, but I think we need to be very cautious about implementing medicines in our practice, especially when the standard is close observation. I would say I would be cautious. I'm not ready to start a PARP inhibitor here.
Okay, Mansoor, what about you?
So I completely agree with Matt, what you just said, Matt. I just want to emphasize that if I look at this in the supplement of publication of DuoE, you can see that how much hazard ratio is for serous and how much is for endometrioid. And if you look at endometrioid altogether, endometrioid is composing of 1/3 of the patients are dMMR, so it's basically very high number, and then very small group also have p53 mute. That goes to the p53 mute classification. So I believe that the rest, which is a pure NSMP, is not benefiting from PARP inhibitor. We have to look at that. Shannon is doing that analysis, and I'm looking forward to see that analysis. So agree. I will not be prescribing PARP inhibitor to all PMMR population. It may be harmful. I would like to see more data. I will have the same problem with Matt when we present the part 2 of Ruby study, because that's another dinosaur trial, and we are going to do the same questioning, and we have to perform the molecular classifications to see the breakdown.
Well, Mirza, I'm so glad you mentioned Ruby Part 2, because we would love to have that presented at San Diego SGO meeting 2024. You're invited. Just throwing it out there.
All right. I'm not allowed to say anything here. I'm conflicted.
All right. On that note, we can move on. So I'm going to have Matt describe the Utola study, and then Flor, I want to come back to you and start talking a little bit about the PDL1 work that was done in DuoE and ATTEND. So go for it, Matt. Tell us about this study.
So, Utola is an all-French study with a mixture of histologic subtypes is shown there. They received 6 cycles of mostly platinum taxane, and if they had a CR, PR, or stable disease, they could be randomized over 2 years of of olaparib maintenance and a 2-to-1 randomization versus placebo. And, good innovative trial, working on all the data we had from MMRD being important in endometrial cancer. They do have a breakdown of P53, MMR status, POLE mutation, BRCA mutations, and an HRD-like score that's been developed for endometrial cancer. And again, about half the patients end up having this score. About 3/4 of the P53 mutated patients have an HRD positive score, and about 79% of HRD patients are P53 mutated. So you can kind of put that into context. But as Mansoor said, we need the PROMIS classifiers. We need to understand who's HER2 positive. Lots of things that are still needed here. And this is with 31 months of follow-up, the PFS curve really showing to be quite similar here. And probably could go ahead to the next slide. And, for the P53 mutation patients, you see that trend, but you see kind of that opposite trend to where, PARP inhibitors are on the wrong side of the curve for the wild type patients. Next slide.
And that's the next one's the HRD status.
Yep. So for HRD, you do see that better signal. If they're HRD for the proficient patients, again, the PARP inhibitor could even be doing a little bit of harm. They did a very nice analysis. I think there's a lot to be learned from this study. It will challenge our Rainbow colleagues for their trial, I think, because this is definitely one that would maybe make me think that are we doing the right thing, launching another trial until this trial matures a bit more. You can go to the next slide. And again, this is probably their best predictive group. It was an exploratory group as they combined both features, P53 and their HRD score, to find a hazard ratio of 0.5 that just, again, this wouldn't, normally a statistician probably wouldn't even let you put a error bar on there since it was not planned. But some intriguing areas where we see some patients that we can identify with our current technology might be benefiting. If you look at the next slide, though, it's kind of the cautionary one. Oops, I maybe have taken out the OS, but that's maybe after these. I just kind of tried the back of the napkin approach, comparing it to the other trials out there. But as you recall, we start at different times. We start with chemo with our checkpoint trials, but I still think targeting this patient with checkpoints probably the way to go. But again, this is very crude analysis, comparing cross-trial comparison, all the things we shouldn't be doing.
All the things we shouldn't be doing, but we do anyway.
Again, we're looking for hypotheses.
This is Dr. Coleman's chart. He loves it.
Yeah.
Let me see what you have next year. Oh, this is IT. So I'm gonna.
Yeah. So, but I think. Oh no, go back one. Go back.
Okay.
Because I think this is OS, which I think is the part where you start saying, "Uh-oh, we might be making things worse for our patients," and especially in those wild types, it's considerably worse. Not quite statistically worse, but it's worrisome. So I would be very cautious at putting PARP in all patients at this point, without a good selection of really those patients that are going to benefit.
Exactly. So I want to go on to Flor, because I'm going to ask you about
here yet either. Yeah.
the PDL1 data from DOE, and I'll try to find those slides. But just kind of off the cuff, what were your thoughts there?
PDL1 hasn't really been shown to be a predictor in the single agent immunotherapy. In the other trials done, wasn't a predictor. In DOE is the only study where they did see a benefit. And I think the biggest question to me is the PDL1, is that just another way of representing the DMMR population? Is that the population that has the highest PDL1 scores? So is that just an alternative measure? And especially since in ATTEND also, when they looked at it there, we don't see a difference by PDL1. And we don't see a difference in ARID1A as a predictor either. All things that have been thought to be predictors in other diseases. So I'm not sure what to think of it. I would like to see more. What is this PDL1 population? Is that the DMMR population? It would be another way to identifying patients, or maybe patients that otherwise would be missed that could still benefit, but like to see more about this.